Hello, good evening, everyone. I'm Dr. Hina Singla, Program Unit of Vision 2020 based in New Delhi. On behalf of Vision 2020 India and Shankarai Foundation India, we welcome you to this webinar on strategies for building volume in community ophthalmology setup. We will run the session for an hour. Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. So let me introduce our resource person, Mr. Senthil Raj. He's a public health professional with over 2 decades of experience in community outreach across India and Africa. So he's currently working as a head of National Community Outreach Program at Shankara Eye Foundation, India. Mr. Senthil oversees Pan India operations, driving large-scale efforts to tackle preventable and curable blindness. I request Mr. Senthil to take off.
Today, we are going to talk about the strategies for building volumes in the community ophthalmology setup. We are going to discuss about the magnitude, the understanding, the barriers, why volume matters, and the strategies to build volumes in this session. Globally, 1.1 million people are living with vision loss because they don't have access to basic eye care services. 90% of vision loss in low and middle income countries. 43 million people are blind and 295 million people suffer from moderate to severe visual impairment. 258 million people suffer from mild visual impairment and 510 million people suffer from presbyopic correction. The numbers of people with vision loss is growing. It is estimated that 1.75 million people will be having vision loss in 2050. 90% of vision loss is preventable or treatable. 100 million people need cataract surgery. 161 million needs spectacles, and 510 million need presbyopic corrections. 73% of people with vision loss are over and above 50 years, and 55% of people are women or girls. Free high-quality cataract surgery can increase household income. Providing glasses can increase workplace productivity by 22%. According to IABP, 44% children can glasses can reduce the odds of failing from the class. The consequence of visual impairment is people are more likely to be unemployed, can have road accidents, or more likely to suffer from depression or dependency, or more likely to have a fall while walking. The major causes of blindness: uncorrected refractive error, cataract, glaucoma, ARMD, and diabetic retinopathy. 64% of people with vision loss live in South Asia and Southeast Asia and Oceania. India, 4.95 million are blind, 35 million people are visually impaired. Every year, India performs around 9 million cataract surgeries with the support of all NGOs and the government agencies. 5,000 per million. CSR is 5,000 per million, and 1.1 million spectacles are given to school children every year. In India, it is estimated 25,000 ophthalmologists, that is 13 per million ophthalmologists, and estimated that 42,000 primary eye care practitioners work in India, which includes optometrists, ophthalmologists, that is 30 per million. Let's understand the barriers and multifaceted challenges. The geographical barriers, why people are less likely taking uptake of surgeries or treatment. This is purely the geographical barriers are far from villages. The hospitals are far from villages, poor road quality, or limited public transport and long travel time. The availability and accessibility barriers are very few trained professionals serves in rural population, limited facility at rural levels, cost of services are high, and long waiting times for surgery. The other major barriers are gender inequality, family decision making, because healthcare choices often controlled by either the breadwinner or the elders, and lack of awareness. Many do not realize eye diseases and availability of facilities. Difficulty in understanding the medical advice is another barrier. Social stigma, wearing glasses or surgery. The traditional beliefs or myths. For an example, in northern region, people don't uptake cataract surgeries during summer. So they have a belief that they have get infection during that period. Hence, they're less uptake in the northern regions. And the economic barriers, you see, the low income prevents many of from affording treatment. They think high cost of surgical surgeries and loss of wage. This is normally during our study also it revealed that a lot of people don't uptake surgeries because the time off from work and they're reducing earnings. And high transportation cost also burdens the individuals on uptake of the surgery and the surgery cost, of course. Why building volume matters in community ophthalmology? We are going to discuss about that in detail. Um, the volume matters because high volumes means surgeons skills improve, so we get better results. The volume, of course, the high volume correlates with better surgical results, as I said. Effective resource utilization, that all equipments, vehicles, and staffs can be effectively utilized, so optimization of resources. And increase access, more patients served. High volume means serving large patients populations effectively in underserved areas. Faster appointments, minimizes the backlogs and improve experience. Higher volumes helps eliminate avoidable blindness and meet health goals. The economics of scale, because higher volume we do, the reduced cost per patients, making service more affordable. The bargaining power increases when we procure medicines or IOLs. So a strong negotiation position which we have when we do volumes. The revenue goes supports funding, cross subsidization, long-term service delivery, and supports reinvestment in technology and staff. High volumes attract young talents to get into ophthalmology, the professional growth, and the team building. High volume centers foster strong reputation collaborations. The strategies to build volume in community ophthalmology are: we have to build trust through community engagement. We have to engage and collaborate with the non-governmental organizations like Lions, Rotary, and the self-help group, women self-help groups, and the faith leaders, be it a temple, church, or mosque, or Gurudwara. We have to have the local partnership so to build our community engagement. Community should own the program because we have to involve the locals, people in planning and executing eye care programs. Every effort counts. So involve the school teachers, ASHA workers, ANMs, self-help group people, panchayat leaders, faith leaders. So every effort counts here. The strategies to build volumes in is mainly we have to create awareness campaigns. Localized messaging should be done. One shoe will not fit everyone, will not fit for everyone. So we have to tweak according to the local settings. We have to be relevant to in creating awareness messages as well. And we have to use the community mobilizers. They are the frontline workers. So we have to use ASHA workers, Anganwadi workers to mobilize patients during the camps and to spread high health awareness and messages. We have to train the local people because Shankara believes in that model. We train people, we pick people from the local area, we train them and we put them on the job at the field work. So empowering the locals will help us to deliver very effectively. As I said earlier, the empowering community health workers is the key for the success of the large volume community ophthalmology programs. Training them, equipping them, be it ASHA workers or any health workers in that matter, we have to provide them screening kit and reward them for successful patient referrals to boost motivation. We have to enhance the health-seeking behavior among the public. So creating awareness, promote regularly the eye awareness programs, use local language and relate messaging to dispel myths, and adopt what suits the local setting, because some regions radio broadcast is very popular, somewhere street plays or community events or WhatsApp, some places WhatsApp also works. So let's use these strategies to increase the volume and increase the footfall of the camp outreach levels. So leveraging technology is very, very important. Tele-ophthalmology can be used as a strategy. AA-based screening or grading images, AA can be used for that. And GIS mapping to identify the service gaps, and cloud EMRs to improve patient tracking and follow-up. With all the strategies, the metrics is the key for the success. So track the key metrics like patient visits, surgeries, procedures are monitored closely on daily, weekly, quarterly basis. OP to IP conversions should be monitored regularly, the GP conversions and the follow-up rate. The post-operative follow-up rate is also important as what we do. We have to take data-driven decisions. For that, we need data. So data has to be collected at the source. Always do a benchmarking, compare against national models, standards, and use EMR or other tools to strategize building the volumes. Shankara, what we do at Shankara, over 4 decades of experience in community eye care, grown from 1 room to 14 super specialty hospitals in 10 states across India. We have 40 vision centers covering 143 villages with a dedicated 2,800 team members. And we have so far performed around 3.2 million people and screened around 20 million people. Shankara works on a replicable model, developed a standard process, a clear blueprint, which is replicable at all centers. We do run a training program, which is we take people from the local and train them, equip them, and put them on the job. So we train them from the grassroots level to the surgeon. So Shankara has a well-documented case studies and best practice. We follow the best practices. And we have a flexible model to different geographical region and cultural contexts. Shankara leverages with technologies. Shankara Electronic Remote Vision Information Center, it's a mobile-based app, Android app, wherein our data is collected during our door-to-door visits. Our field workers effectively use this app to collect data. Patients who are referred to an outreach camp or to base hospital, a QR code print, a referral slip is printed and given at the field. So the patient takes the slip, the QR slip, goes to the camp. The field worker or the camp organizer scans this and takes all the data. So there is no duplication of entries at the camp level, because all the data are collected at source. So, once the examination is done, patients are referred for surgery. The same slip, the patient takes the same slip to the base hospital, and where in the base hospital we scan the barcode, and the patient's informations are directly transferred. So it's a seamless activity. So it's a paperless models which we practice in camps. And we use effective dashboard for monitoring the field workers' attendance or data flow. And the GIS tagging helps us to map the diseases, and effective door-to-door follow-up through GIS. These are some of the GIS maps which shows tracking of patients, diabetic patients who have been grouped, and the follow-ups have been on the right side corner images. The satellite images shows us the follow-up dropout patients, so that our field workers can go on visits the patients at their respective homes. Shankara strongly believes on data-driven approaches. So our live data dashboard helps us to monitor all the 14 hospitals and the field works, and regularly gives us information to take informed decisions. Shankara has a vehicle management system fitted in all our patient transportation vehicles. We do have live tracking and monitoring, which helps us in effective planning and scheduling the vehicles. So thus the empty trips are reduced. So we have a lot of cost savings in with the effective planning, and speed control systems have been placed in all the vehicles to ensure safe travel. Shankara has mobile rural vision vehicles, wherein a comprehensive vehicle fitted with Remedio devices, refraction units, slit lamp, and NCT, wherein the vehicle travels to the interior villages, unreached areas, tribal regions, and teleconsultation has happened from the remote villages. Shankara has 40 vision centers across India. We have 4 regional teleconsultation centers, which is linguistic-based teleconsultation center. For Tamil-speaking regions, we have Coimbatore as a base, and Telugu as a speaking region. We have regional teleconsultation center at Guntur, for Kannada region at Shimoga, and for all Hindi-speaking vision centers at Kanpur. Yeah, Shankara uses always uses technology, leverage on technology. Bot we effectively use bot for automated data collection, basically from our EMR to upload data in the NPCB portal. So the bot validates the data, ensures the data error-free, and which runs with a minimal human intervention, which saves a lot of time and effort, and the bot is very quick to upload data. The key takeaway messages, whatever we have seen during this presentation, is we have to increase volume. We have to recognize the barriers, and we should be collaborative. We should go with a collaborative approach, partnership with governments, non-government, and the local governments. We have to implement sustainable solutions. We have to always invest in long-term initiatives rather than the short-term approach. We have to always embrace with teleconsultation or the technology using AI. And we have to empower the community. So we have to educate and enable the local population on eye health. We have to collectively work to reduce the avoidable blindness. So thank you all. Over to you, Dr. Hina, for question and answers.
There is one question. Would you like to have more details about QR generator and GI tagging?
So what happens is, it's a mobile-based Android application wherein our team goes to the field and collects data. The lat and long data are captured, and it has been mapped with the satellite images. So we can track the movement of the field worker. We can track the disease pattern. So we can map all these details.
Thank you, sir. The next question is, what are the strategies or ideas to get more patients during summer season?
The constant awareness creation is the key to make it happen, because summer is a big challenge in the northern regions, especially because people have a myth of heat wave and surgical infection, which is not. So constant awareness, work closely with the faith leaders and the community leaders at the local level, so that will improve the uptake of healthcare services.
Yeah, thank you, sir. The next question is related to the app only. Is it your own developed or available freely on Play Store?
No, it's exclusive. It's developed for Shankara thing. It's not available in App Store.
Okay, sir. Next question is BOT technology, how it works. Do you feed the data to it and how does that audit the data?
Come again? Sorry.
So BOT technology, how it works. Do you feed the data to it and how does that audit the data?
No, how it it takes from our EMR and takes the data and autofills it in the NPCB portal. So it validates the data and open up the NPCB portal and fill the respective data there in the columns or in the fields. What?
Yeah. Next question, the process of referral from door to door with QR code, how it works.
Okay. See, during the field work or the door-to-door survey, our field worker goes and identifies people who require further treatment like cataract surgery or further evaluation. So the field worker carries with a Bluetooth printer. Once the details are captured in the mobile app, a referral code is generated, which the field worker takes a printout, which has a QR code, and the patient brings the slips to either to the camp or directly to our base hospital. So that slip has a barcode, and the barcode is scanned, and all the details are transferred. It is seamless.
Thank you, sir. Next question, do we need an internet connection for this app? Most rural part of India lack proper network connectivity. So how will the application help community workers in such areas?
Yeah. Okay. We have a local storage facility also. Some regions doesn't have poor connectivity or no connectivity. So those areas, the data are all stored locally, and when the field worker comes back to their respective workplace, the internet once the internet is connected, the data gets synced or uploaded.
Next question is how do you measure the outcome of various promotional campaigns like auto publicity, WhatsApp, radio? You do.
Yeah, see, data is the key here. At the camp level, you have to collect data of the source of information.
Yeah, thank you. NPCB software doesn't have the facility to upload the data, and they said it would not be possible. How did you get linked for uploading the patient level data?
No, NPCB portal is just a web portal wherein our bot takes the data from our EMR and posts it into there as if you are keying, because manually you're keying, the bot does the data entry.
How are you
It
tracking
copies
your? Yeah,
it copies the data from our EMR and places it in the NPCB portal. Yeah.
okay. How are you tracking your non-compliance patients by GPS? Can you please elaborate?
Yeah, see, what we do is we during the door-to-door survey we collect patients lat long, right? Those patients come for surgical thing. They have the QR code. Their GS tag is mapped. So once the patient turns up for the review, so who are all not turned up for the review, those patients are all followed up at door-to-door screening.
Who are the key players in community eye care in India, and do you feel is this enough to cover the entire needy population? What more needs to be done to cover the entire needy population?
More service providers should be encouraged and uh, to coverage, increase the coverage. The existing major players should do more coverage is the key. Yeah.
Okay. If an organization wants to implement or start geotag application, what are your key suggestions?
Okay. One is investment. Investment is the key there because it involves a lot of cost in development. And we need a sizable number of field workers to do that because institutions have less number of field workforce, should not invest in that. People have more workforce on the field should effectively take up that model.
Okay. Next question is my hospital is surrounded by three more eye hospitals, all 8 kilometers apart. How to compete with other hospitals, as all the hospitals are going to same panchayat blocks or districts?
Yeah, quality speaks quality and your patient referrals. So your own beneficiaries will bring more patients. We have a concept of each one catch one concept that patients, our own beneficiaries will bring patients to us. Yeah, competition is will be there in all regions. I don't see this competition. It's an healthy thing. Service providers who caters to reduce the backlog. Yeah.
What is the second strategy if the referred patient not reach the camp place?
Yeah, we do collect phone numbers. In our case, we do collect phone numbers during the door-to-door survey. So we call them and remind them. So SMS are sent to them. So these are the approaches we adopt.
How to sell glasses on camps?
Now, there are two approaches. One is you can take order and deliver it at later point, or go with a fitting unit and fit it and deliver it at the camp level. And another easiest approach is the dispensing presbyopic glasses at the camp.
How many camps do you organize per year?
Okay. See, we exist in 14, we have 14 hospitals and around 10 states. See, approximately we run around 4,000 to 5,000 camps a year.
How to ensure that patient is fit when taken to base hospital for surgery?
Sorry, come again.
How to ensure that patient is fit when taken to base hospital for surgery?
Yeah.
Patient fitness.
Yes, yes. We check their blood pressure and sugar. Random blood sugar is tested at the campsite, and we do the physical examination. At some places where general physicians are available, we engage them to give fitnesses.
Next is, what is the average footfall in your community eye screening camps?
So ideally, if you have 100 footfall in a camp, that will yield you around 25 surgical patients. So, which is really a decent number in some areas. Yeah.
Okay. What is the training duration for community health workers, and what are you providing in a screening kit?
Okay. For the ASHA workers or the community health workers, the training is varies between 4 hours to 6 hours. Um, the training kit is a torchlight, a vision chart, near vision chart, and a distance rope and a bag.
Okay. Uh, there is an AI tool being used to enter data into DBCS portal. Are you monitoring it? Because we can't assume that AI is completely error-free.
Yeah. No, the AI is not doing any data entry. It is just capturing the data and placing it in the respective cells. And our bot is tested and tried effort. So it's mostly error free.
Okay. How do you
And we have a
decide?
quality check as well. We regularly monitor and the quality checks are done.
Okay. How do you decide where to establish telecommunication centers? What are the key solutions you are providing with teleconsultation?
Okay. The teleconsultation which we do is it's a linguistic based regional teleconsultation center which we have established, and the images are all captured at the vision center using a Remedio, and AI tool is used for grading the images in terms of diabetic retinopathy, and live teleconsultation is done, and the doctors at the regional teleconsultation talks to the patient and medications are given accordingly or treatments are given accordingly. Yeah.
Okay. In Tamil Nadu, how much is the volume of surgeries through CAMs?
Come again. Sorry.
In Tamil Nadu, how much is the volume of surgeries through CAMs? Volume of surgeries through CAMs in Tamil
Uh,
Nadu.
in Tamil Nadu, around 8 lakh surgeries they've done last year.
Okay. Uh, so the participant want to get an answer again on how do you sell glasses in a camp?
See, there are two approaches. Either you go with where you collect orders, right? Refraction is done. So prescription is given to a particular patient, where orders are taken as sample frames are kept. Orders are taken with using the sample frames, and the glasses are made at the fitting lab and deliver it at a later stage. That is one approach. Now, another approach is going with a fitting facility to the camp and deliver it. There's another approach which recently evolving is the pop-in lenses, wherein the ready glasses are available and the frames, fixed frames, where can be fit in and delivered immediately. The fourth approach, as I said earlier, is the presbyopic correction, where you can disperse the reading glasses at the campsite. Yeah.
Okay. How do we need do we need approval letter from CDMO or any government authority to organize refractive error screening eye camps?
Yes, required. It's required.
Okay. Next is what is your average OPD per vision center and how many spectacles dispensed per month?
So come again. Sorry.
What is your average OPD per vision center and how many spectacles dispensed per month?
See, in average, we see around 1,000 patients a day, and our conversion rate is around 6 to 7%.
Okay. What are the primary reasons patient at the campsite are declining and not being selected for surgery?
Means the patient has been declined for surgery.
Yeah, for not being selected for surgery.
There
Declined or
might be
not being
multiple.
selected.
Yeah, there
Yeah.
might be multiple reasons like fitness, right? The general fitness is one of the reason.
Okay. Whether all the patients visiting vision centers are undergoing teleconsultation.
Yeah, 98% of our patients are all undergo teleconsultation.
Okay. Next question is what is the biggest challenge in community eye care today?
Um, See, the biggest challenge is uh, community mobilization is the biggest challenge now because a lot of service providers, so there are more caregivers, so patients have a lot of options. So bringing footfall is the major challenge now.
Okay. What are the benchmarks for deciding on minimum OPD in adult camps, surgeries, refraction, and glasses, along with specialty camps?
See, the benchmark for the outpatient or the surgery, it depends upon on the service provider. Basically, their volume which they can perform in a day. So a lot of parameters involved in this to decide that factor.
Okay, so we are done with the questions right now. Um, yeah, I think all questions are covered. So we can wait for a 1 minute. Yeah, next, yeah, we have two more questions. How are you
Yeah.
ensuring partnership with local volunteer organizations? How do you select them?
See, we um, work with NGOs, the local leaders. Sometimes we work with the faith leaders as well. Um, we our field team go and visits them, interacts them, sees their potential, evaluate them, and we get into a letter of understanding and we engage them with them. That's our Shankar's model. Yeah.
Okay. Why majority of surgeries are cataract and not specialty surgeries performed?
It depends upon the facility by the service provider. If they don't have the multi-specialty or super specialty facility, so some organizations, some service providers stick to cataract surgery. At Shankara, we largely practice as all surgeries are taken up from the camp. Yeah.
Okay.
And majority is all cataract because the prevalence rate is high.
Next is what is your proportion of walking and outreach cataract surgery?
See, Shankara works in 75-25 model. 75 patients, 75% are free and 25% are paying patients or subsidized surgical patients.
Okay. How do you ensure sustainability of vision center?
Okay. The first key point is to increase footfall by creating awarenesses and promoting the vision center. So increasing the footfall is point number one. Second is prescription to glass optical order conversion. That's another key. And keep your cost always low. So these three parameters will make the vision center sustainable.
Okay. Next is insights on the reaching unreached children screenings.
Yeah. Shankara's experiences, our two major flagship programs are Gift of Vision. Gift of Vision is our community rural outreach program. And Rainbow. Rainbow is our school eye screening program, wherein we do train the teachers for the preliminary screening. And our team goes there. The teachers select the defective patients, and our team goes there and screens the defective or shortlisted patients. And children who require glasses, refractions are done at the school. Where children who require detailed examination or compound powers are referred to base hospital, wherein detailed examination is done by the pediatrician, and respective treatments were given to the children.
How to overcome the PHC area allotment to get more OP numbers?
So come again, please.
How to overcome the PHC area allotment to get more OP numbers?
No, we have to closely work with the government, because sometimes what happens is a lot of service providers in the same area. So some local governments, they allocate PHCs. So another approach which we can do is, instead of PHC attached with the PHCs, we can request the government to give permissions to conduct camps other than PHC levels.
Do you send ophthalmologists in your camps, and do you do refraction in camps?
Okay. Some of our camps, the team comprises of ophthalmologists. In some areas, the refractionist or the frontline workers do the screening.
Okay. Next is how are you designing a community outreach activity? How many staffs involved in an iCamp? And how do you choose the location, and how do you ensure the camp is successful?
Okay. The key success for any outreach camp lies with the collaboration with the local co-sponsor. They are the key people who takes care of the community mobilization, creating awareness or the promotion. So and the locations which we choose is all data driven, data based decisions which we take. We see the geographical area, the service providers, our experiences. So these are all the key factors for a decision of a camp. What was the third question? Sorry, what was the third one?
How many staffs involved in an iCamp, and how to design community outreach activity?
Okay, the staff varies from 6 to 12. That does purely depends upon the footfall which we anticipate for in a camp. So that's based on the camp's predictions.
Okay, and who bears the publicity costs in a camp, sponsors or Shankara?
Yeah, most of the areas, the co-sponsors takes care of the publicity.
Okay. How is the patient satisfaction being measured post-surgery?
Yeah, Shankara has a AI-based multilingual software, which is called Sahai. We do collect data. People can talk in their own mother tongue languages, regional languages. It gets converted. So data are captured at all levels. And the data is analyzed and it is readdressed. We have a
Okay.
proper mechanism of taking feedbacks. Negative feedbacks are reviewed, and if required, it has an escalation method as well. The software has an AI tool which escalates the respective levels. Yeah.
Okay. How to motivate field staff regularly?
Regular interaction, meeting them regularly, and setting achievable targets to them is the key for motivation. See,
Okay.
support them, and make them achieve. Also, rather than driving them, making them work with them to achieve the numbers.
Okay. Yeah. Uh, so we are done with the questions. So, and we are about to conclude the webinar. So thank you all for attending today's webinar. We appreciate your time, engagement, and thoughtful questions. A special thanks to our speaker for sharing their expertise. We also thank our corporate advisory board members for their support. So we hope you found the session valuable and looking forward to see you at future events. Thank you once again. Thank you, Dr. Senthil, for
Yeah,
this
thank you,
insightful.
Dr. Hina, and the entire team for organizing. Thank you, Cybersight and Vision 2020 for
Yeah.
organizing the fantastic event. Yeah, and
Yeah.
thank you for all the participants who are very interactive in asking questions. Really, thank you all the participants for attending this program. Thank you.